I'm ready when you are, Michelle.
It's all yours, Dr. Chua. Thank you so much for hosting today. We really appreciate it.
No problem. Can everyone see the PowerPoint presentation? Okay.
Yes.
Good. All right, then I'm going to go ahead and get started. So hi, for those of you who don't know me, I'm Dr. Catherine Chua. I'm a DO, graduated from the West Virginia School of Osteopathic Medicine. I have a master's degree in population health. It's my passion. I absolutely love it. I am a family practitioner, have been practicing for some years, and that's probably, and I'm the Chief Medical Officer here at Davis Health System. So today we're going to talk about improving your chronic disease management program. For those of you who are going to be going to the conference in May, I'll be talking in much more detail about specifically chronic care management. This is more of an overall how to improve management of chronic disease in your clinics. So the description here is to learn how integrating disease management best practices drastically impact outcomes and find out how you can empower your patients to be active partners in managing their chronic disease. Here are our learning objectives. I won't read the slide to you. So what is the evidence for clinical and financial impact of management of chronic disease? 90% of the nation's $4.1 trillion in annual healthcare expenditures go towards people with chronic and mental health conditions. So over 85% of Americans over 65 have at least one chronic disease. In 2012, 50% of adults had one, and 25% of those had more than one. So between 2012 and 2024, we've gone from 50% of adults over 65 to 85% of adults over 65 have a chronic condition. There are about 695,000 people in the United States who died from heart disease in 2021. That's 1 in every 5 deaths. Effective blood sugar management can reduce the risk of eye disease, kidney disease, and nerve disease by 40%. Blood pressure management can reduce the risk of heart disease and stroke by 33 to 50%. And improving cholesterol levels can reduce cardiovascular complications by 20 to 50%. Using team-based care that includes a pharmacist could prevent up to 91,900 heart attacks, 139,000 strokes, and 115,400 cardiovascular deaths over 5 years among U.S. adults with uncontrolled hypertension. That could save Medicare up to $900 million over 5 years just with that intervention. So as you can see from the slide, this is the total cost of heart disease, diabetes, and hypertension to the healthcare system. And then with heart disease, there's even a statistic of how many billions of dollars are lost in productivity on the job. So the cost of management of these diseases is quite high. One of the ways that we look at the cost and savings of interventions for chronic disease is to look at something called the quality adjusted life year. So the quality adjusted life year is a generic measure of disease burden, and that includes both the quality and the quantity of the life lived. It's used in an economic evaluation to assess the value of medical interventions on the healthcare system. So one QALY, or quality adjusted life year, equates to 1 year in perfect health for a patient. Any intervention that costs less than $50,000 per QALY is considered to be cost effective. So if it costs more than $50,000 for the 1 year of perfect health, then it's not cost effective. So when you take QALYs into account, intensive lifestyle management for type 2 diabetes costs $12,500. So that would be considered a cost-effective intervention. Self-monitoring of blood sugar for type 2 diabetes 3 times versus 1 time a day costs $3,700 per QALY. Screening for eye complications every 1 to 2 years is $8,763 per QALY. Annual screening for chronic kidney disease is $21,000. Team-based care to improve blood pressure control costs anywhere from $9,700 to $13,000. And then community health workers cost $17,000, and self-measured blood pressure costs $2,800 to $10,800. So all of those interventions that I just listed are things that you can easily implement in your practice and with your patients that are cost-effective interventions. They all cost less than $50,000 per intervention. So what stops us from doing this well as physicians or as practices? There's something called the dual task theory. And the dual task theory suggests that when confronted with multiple different tasks, individuals first perform those in which they have the greatest emotional involvement. So when a patient presents to the office with symptoms, physicians are driven by a fear of missing serious diagnosis, and therefore they'll focus all of their attention on the symptoms as opposed to doing a routine assessment, counseling, or other elements of good chronic illness care. So for those of us who are doing this work, somebody comes in for their regular 3-month checkup and they say, I've had a cough for the last 2 weeks. I'm most likely, because of the dual task theory, going to spend the majority of the time talking to them about their cough and therefore not spending the time addressing their chronic diseases. So in order to get to where we need to be, medicine as a craft or as a profession is moving from a craft-based practice, which is individual physicians working alone. You don't see that often anymore. We're all part of bigger groups. Handcrafting a customized solution for each patient based on core ethical commitment to the patient and vast personal knowledge gained from training and experience. We're moving more towards a profession-based practice where we have groups of peers treating similar patients in a shared setting. We plan coordinated care delivery processes. So you think about order sets, you think about the standards, the MIPS things that we're trying to hit for each of these patients. Individual clinicians adapt to specific patient needs, obviously, but early experience with this kind of a model shows that they're less expensive. The facility can staff, train, supply, and organize to a single core process, less complex, there's fewer mistakes and dropped handoffs, and better patient outcomes. So that's how the profession is moving to get to the point where we can really focus better on chronic care management and to move away from this dual task theory. So our training, our time, our resources, they're all moving in that direction for better patient care. So how do we overcome these barriers that are keeping us from doing good jobs? And I think, I don't want to say we're not doing good jobs. That's really not the right way to say it. We all do a great job with our patients. But on the other hand, you look at the state of medicine in the United States, and we spend the most money, we have the sickest patients, we have an increasing neonatal mortality, more so than any other country in the world. So yes, I think as individual physicians, we're committed to doing a great job, but as a system, we're missing the boat. So how do we start to overcome these barriers and do best practices for our physician or for our patients in a primary care setting, and to control these chronic diseases? So the 3 things that they talk about are empowerment, education, and collaboration. So for example, here at Davis, when we started our population health program back in 2015, I believe, 2016, we started having monthly and then moved to bi-monthly population health meetings. And we had all of our primary care providers come to this meeting and collaborate over what we felt were the best practices for certain chronic diseases. So we would gather information from the AAFP, the American College of Internal Medicine, the American College of Cancer, American College of Urology, American College of Pediatrics, and we would get together and look at all the recommendations, Prevention Task Force, what's the other one? Choosing Wisely. So we would look at all of that information and we'd say, okay, not only what is the best practice outlined, because it's different in each, one of those colleges. For example, urology versus family practice and the PSA. The American Academy of Family Practice says don't do a PSA routinely unless they meet certain criteria. American College of Urology says do them for everyone. So, we kind of had to educate all of our providers and empower our providers to make those decisions and then collaborate to say, What is it that Davis Health System wants to look like when it comes to treating chronic disease? And as we did that, we also talked about the cost of certain interventions as well. So we would look at not only what is the first, second, and third line medication to treat diabetes, but then how does that look cost-wise for the system and for the patient? So, I'm sure that a lot of you have had the issue with Entresto, which is a great drug, but when somebody's discharged on Entresto from the hospital and come back to their primary care, I'd say about 50 to 75% of my patients say I never picked it up because it's expensive. The copay is too expensive. So having those conversations too, because if they're not picking up the medicine, you're not controlling their chronic disease. So I think that those are important. And that also takes away the mentality of you can't tell me how to practice medicine. This is cookie cutter medicine, because it's not. You're collegially coming together to discuss best practices. And of course, it doesn't work for every patient, and we understand that. But if you have some guidance to go by, it makes it much more it makes it much more efficient for the patient, and you get better outcomes. So we can also overcome that dual task theory by actively and aggressively scheduling annual wellness visits. And I know you guys have heard this before. You're going to hear it again. The annual wellness visit is super important to address these chronic conditions because of the dual task theory. So these visits tend to be longer than 15 minutes, and they involve all levels of our practice. So the way that we have done that here is that the patient's scheduled to come in for their 3-month follow-up or whatever, and then we have the population health LPN actually do the annual wellness visit.
West.
I'm sorry? Oh. The population health nurse will come in and do that annual wellness visit, and then be able to communicate with the physician afterwards and say, for example, maybe the patient didn't get a chance to tell me, oh, I haven't picked up this medication, or it's too expensive. The nurse will come and talk to me, and then we can really then address those social determinants of health in a more effective way, rather than me trying to do that in the 15-minute visit. Empowering the LPN to do this not only finds issues, but it allows them to also say, hey, this person needs a mammogram, they need their hepatitis C screening, and those sorts of things that I may not have gotten a chance to address in the meeting because the patient told me they've been vomiting for the last 4 days or something. So we allow our nurses to work to the highest level of their license. We're using nurses as health coaches and educators. They do guide us on some of the screening tests that need to be ordered. Community health workers can work with patients on motivation and exercise. We do have a nurse practitioner that does home visits because we know that there are people who just can't get in to see the doctor. So when we identify that person who's struggling, then we refer them to the nurse practitioner, who then starts to see them in the home. And then in the trials that they've done on this, much of the plan of care was delegated to these key non-physician members of the team, including nurses and pharmacists. So there's also alternative visits, group visits that allow a sense of camaraderie and collaborative goal settings. We haven't done that here, but that is a model that has seemed to work for places like ChenMed, where they bring in a group of people with type 2 diabetes who have poor control, and they do a group visit with that group, and then it's almost like a community sharing. Home visits provide better safety for the frail patient, and they give you more deep trust and connection. And then, of course, the annual wellness visits to take away that dual task theory problem. So then also empowering patients to have a hand in their own care by initializing projects like a COPD sprint, for example, which allows for fewer ED visits and a more invested patient. So a COPD sprint is something that we're doing here. And what that is that every patient who has COPD is given some instruction and a paper that they can take home with them, and it's sort of the red, yellow, green. If you're in the red, you probably have gone too far. But if you're in the yellow, I have already, as the physician, called in a rescue pack for that patient to their local pharmacy. So if they're in the yellow, they're instructed to call our population health department, say, hey, I'm in the yellow. There's a scoring rate based on how they're breathing. Then the nurse will instruct them to go ahead and go pick up their rescue pack from the pharmacy, which includes an antibiotic and a steroid. And then that nurse schedules them a follow-up within the next 2 days in our clinic so that they can be addressed. And that hopefully empowers the patient to really take control of their COPD, as well as decreasing those unnecessary visits to the ER. And you can do that not just with COPD. We're looking at one for CHF and one for diabetes now too. So what are the best practices in disease management? So significant variation from evidence-based practices leads to poor outcome management. Utilizing standards of care decreases costs and variation and improves outcomes. It's been shown over and over and over again. And I have some slides coming up next. I'll show you some examples of what care process models look like. The hypertension detection and follow-up trial reduced all-cause mortality by 17%, and the diabetes control and complications trial, both of those specifically delineated care models, including specialized clinics, explicit plans, regularly scheduled follow-ups, systematic assessments, and attention to self-management needs. Patients and families were included, and all materials and methods were designed by behavioral scientists. Both of those trials had very good evidence-based results on improving chronic disease management. So the first thing is evidence-based planned care. That's the top of the pyramid. Then you talk about practice redesign, patient education, having an expert system, and information. Those are the 4 pillars of evidence-based practice. So we'll talk briefly about each one of these levers as we go through. So evidence-based planned care. Standardization of care is important. So this is variation in practice patterns for different types of low back pain, GERD, statin therapy, et cetera. And you see that there's a lot of variation amongst different providers in all of these practices. And that leads to lower or worse outcomes for patients. This right here is called a care process module. This is something that Intermountain Health System puts out for their physicians. Unfortunately, they used to actually put them out for all physicians, but they stopped doing that. So I was lucky to have a screenshot of one I could throw up here. But this is just something that you can refer to. And you know, we did something similar here as we started talking about those standards of care for all of those different chronic diseases. We've developed a document that's sort of a living document. It changes from year to year based on changes and recommendations, but it's actually housed on our intranet. So one of the things that we worked on was anticoagulation, which is such a bugger for primary care because we're always asked, can this person stop their, medicine before this procedure, or, having to manage INRs and things like that. And that's a big legal pitfall as well. So now on our intranet, we have a standard setup for anticoagulation that anybody can just go to the drop down and run through the algorithm. And then we're practicing similar ways when we're, as a group, when we're adjusting Coumadin levels and things like that. So, that's something that took us about a year to get up and running. But now once a year, we just go back and say, okay, let's revisit diabetes and see what new drugs are out, what new recommendations there are, and then we update it as we go. So practice redesign, working to the highest level of your license, as we talked about. Nurses as health coaches and educators. Nurses can put in the orders for the screening test. Obviously, the physicians have to sign off on that, but they can put it in for you and have it teed up for the physician, so the physician is spending less time doing those things. Having community health workers working with patients on motivation exercises, all of those things that we talked about can be involved with practice redesign. So it's sort of a physician as the director or as the conductor, and then you have this entire team that's working with the physician to make sure that the patient gets their needs met. And that includes a pharmacist, and it includes your nursing staff, and hopefully it would include community health workers and home visits as well. Part of that practice redesign is to make sure that your annual wellness visits are getting done, because that's where you're going to be catching those things that you're maybe not catching in your 15-minute follow-up visit. Reorganize to meet the needs of patients who require more time and resources. So, as your population health team grows, you're doing more chronic care management, you're going to notice, hey, this person really requires a little bit of extra time. And one of my favorite stories ever is one of my patients who I enrolled in chronic care management because he kept coming. He was in the hospital all the time. And then he kept coming in and he had his trash bag full of medicines. And he's like, I don't know. And I'd sit down with him and we would go through his medicines and we'd write everything out. And it was happening once a week. And he was getting hospitalized probably every 2 to 3 weeks with fluid overload or with dehydration. You know, it was just, he was a mess. So got him enrolled in chronic care management. And actually, I sent our home visit nurse practitioner out to his house just to see if there was something in the environment that was causing him to be so confused. And what ended up happening was this man, whenever he got a 90-day prescription from a doctor, and he was seeing me and a cardiologist and a pulmonologist and a neurologist, and a psychiatrist. So he had 5 different doctors. Every time he got a 90-day prescription from somebody, he would go home and he would put that 90-day prescription in pill bottles or pill boxes. And he would hold on to those pill boxes and take those medicines until that 90 days was up. So if he came and saw me and I said, hey, your blood pressure is high, we're going to bump up your Benicar. He'd be like, okay. I would bump up his Benicar, say from 5 to 20, and he'd go get it filled. But he still had the 5s in his 90-day supply. So he'd put that 20 aside. But then the cardiologist would see that I bumped him up to 20, and he'd go see the cardiologist, and the cardiologist would say, oh, 20 is not working for you. I'm going to put you up to 40. But he's never taken the 20 because he had his 90 days already doled out. So that's what was happening with this guy. And the nurse practitioner was able to figure that out. And so we got him down to just doing 14-day pill boxes. And then we kind of let the whole team know that that's what he was doing as well. So we were checking with each other and making sure that he was, you know, the population health team was making sure that he was getting the right drugs filled at the pharmacy and that things weren't changing too fast. So that's where that reorganization to meet the needs of patients who require more time or resources, he was definitely one of them, but he didn't, after we did that, he did not go to the hospital for a year. So it was very effective. And then, you know, alternative visit models and then patient-centered medical homes, which we all, I think, are pretty aware of. So self-management, patient education, reaching out to patient in between visits, that's where chronic care management can be very helpful with education, reminders, and support. Make sure that your staff is trained to be health coaches with motivational interviewing. Encourage diabetes self-management, engaging in activities that promote health and build psychological reserve. Have your patients monitor their own physical and emotional status and make appropriate decisions based on that. And this is just an example of the COPD sprint, but you can do that for any, you know, chronic disease to say, here's ways that you can manage this at home. And I have this population health team who's going to help to support you, and or my nurse can help to support you as well. But these are things that when you get to this point, this is when you call. So having that, those nurses trained to do that kind of interviewing is very effective in a practice. So the expert system, you need access to specialists. We all do. We need the providers educated in best practices, and we need provider decision support. So I think it's important that you make sure that your staff has and uses up-to-date or something like that for decision support, because medicine is changing so fast right now. I did a lecture about a year ago, and I was reading about the turnover of medical information, and it's gone from turning over every, I don't remember the exact statistic, but from when I trained, it was turning over every 1 or 2 years. And now for people in medical school, it's turning over every couple of days. We're coming up with new information in medicine. So without good provider decision support, you don't have the whole expert system in place. CMC is doing a great job with their mobile clinic to give access to specialists to some of the rural areas, and that's been super helpful. And then things like this for provider education are really important. Monitor your referrals. Are your patients getting what they need? And then make sure that you're having collegial discussions with all of your staff. Communicating information is another arm of that. So make sure that you have, you're using your chronic care management, your transitional care management. Those are so important to get that information back and forth from the physician to the patient. Share your information transparently with all members of the team, allow your team to be an effective part and an important part of this patient's management. Your nurses will thank you for it. They feel like, if when they're working to the highest level of their license, they really feel like part of the team. They get to know the patients better, and they're such a good resource for us. Make sure that you're tracking outcomes when you can, that you're providing feedback, that you're receiving feedback when it comes, and that you're working on care planning with your patients actively. So how do you implement this? So strategies to increase your team is practice service reorganization, workforce development. Again, train your nurses up, train your doctors up in best practices. Patient support, make sure that they have those phone numbers so that they can call when they need to. Financial incentives, one of the things that we need to look at more as a system, I think, is, when we do get shared savings, what happens with that? Obviously there's administrative burden, but are we able to financially incentivize those providers that are doing a really good job, or their nursing staff that are doing a really good job, with a portion of that shared savings when and if we achieve it? Because it's a lot of work to get there. And then look at your community health needs assessment. What's needed to provide the best care for your patients? That's so important. You need to look around in your community and say, what else do we need to support our patients? And then how do we, as the local healthcare system, get that to them when they need it? So just a quick touch on, this is part of the reason why it's difficult to do this right now, because so many contracts are still fee for service. So you've got larger panel sizes, you're paid on WRVUs. We all know this. Emphasis on more procedures and treatments, whereas value-based care is moving towards smaller panel sizes, higher quality. Salary and incentives are based on good outcomes and performance. Hospital care when necessary, but not, to make money. And then, so we need to be advocates in our own networks and in our own country to start moving towards this value-based care, because that's better for the patient. Right now, we're being incentivized to provide poor care, and we need to move away from that. And we're not going to be able to do it without physicians advocating for that, or providers in general. So start to make the move to value-based care for your patient's health. Other innovative things: telemedicine, telehealth, direct to patient. I mean, we've all seen, because of COVID, how quickly we could pivot, how much patients truly benefit from telemedicine and telehealth, particularly in the more rural areas, I think, because they have a difficult time traveling to get to the hospital or to the clinic. We should be using more remote home monitoring, oxygen, weight, glucose sensors. Those types of things, as technology continues to advance, are going to be very helpful in chronic disease management. The more we can do that, I think the more we're going to keep our patients out of the hospital. Benefits of telemedicine: decreased travel time and costs for the patient and the provider, care to rural areas, as we've talked about, and then data is available at the point of care. So you can actually get insight into the patient home environment, which I've always loved. When I'm doing telemedicine and my patient's cat curls up on their shoulder or something like that, you really get a better idea of what their living environment is like and what makes them happy. So I think that that's a really nice way to get to know your patient better. Some other things coming up: in interactive voice response, so home monitoring, engagement, and education. Exam room assistance, so that I can't think of the name of it, but having that voice response so that the doctor can focus more on the patient and less on the chart. Post-acute care, home care with interactive voice response. And then they're even doing Siri, Alexa, and some other of those modules to interact with physicians or physician teams in order to keep a closer eye on patients who need it. So we're going to see a convergence with telemedicine and telehealth coming very quickly. So the call to action, like I said, working to the highest level of the license for your nurses is so important. Using them as health coaches and educators, community health workers, home visits, alternative types of visits. All of those things are things that we can be implementing in our practice right now in order to better improve our chronic care management. So key takeaways: we need to advocate as healthcare providers for value-based care. We need to actively engage our patients, make sure that they have a say in what we're doing with them, and implementing team-based care in your clinics. Clinical staff, again, practice the top of their license, educate physicians about standardized care or care modules, and then embrace technology as it comes, because it's going to be a way that we can truly keep better track of our patients. And then finally, the annual wellness visit to take the dual task theory out of the equation. My appendix is just my references. And then this is a summary of the most effective strategies for interventions for certain things. So chronic disease for diabetes, and then episodic care and prevention pap tests. So it's just a reference slide for you. And that is all that I have. I tried to rush through that. I'm sorry if it went too fast, but I wanted to make sure you guys had time for questions at the end. So.
Dr. Chua, that was really good. Quick question for you. Based on that example you gave related to the pill box, which I think we've all kind of ran into that with our populations, what would you recommend as kind of the best tool that for that to help manage the medication? Is it a 1 week, or, I mean, I'm just curious because I'd love for us to have some conversations with our payer partners on how they could potentially support the initiative.
I think ideally we wanted him to go down to 1 week pill box, but he just, part of his issue too, I mean, he saw psychiatry, he's also obsessive compulsive disorder. So, it was difficult for him to go from 90 days down to 2 weeks. So we compromised on 2 weeks. I think a 1 week pill box is better. I also think that the more that we're able to share within the EHR, the better, because with this particular patient, most of his physicians were in Epic. And so I was able to send messages very quickly to all of his physicians and say, hey, here's the problem. We all need to just kind of take a step back. I got a list from his pharmacy, my team got together and we made up a med list and we sent it out to each one of his providers, so that we weren't doubling and tripling up medications. So I think that effective communication between the care team, and to me, I get all passionate about this, but that's what a patient-centered medical home is all about. is right. we are the hub, and that's our job. But I can't do that all the time as a physician, right? So I need a team who can work with me to make sure that we know every one of those doctors, and that every one of those doctors is communicated with when we make a change like that. I think that communication is just so important. And it's going to get easier the more we are all on the same EHR. And then for those people who are outside of our network, hopefully we'll only have 2 major EHRs in the state and we'll be able to communicate better with each other. I see Nancy has her hand up.
Yes. Hi, Dr. Chua. I have a question. It's more of a question or sort of a comment too, because I agree with a lot of the things that you're saying about chronic care management and quality. One of the things that I think we all run into is no matter how much we do to structure things to improve our quality, we run into roadblocks that are something that maybe as a group we can work towards doing something about. And that is that CMS expects us to adhere to these quality measures, but they set up certain roadblocks. For example, they require copays and deductibles for things like chronic care management, for RPM, for assessing a patient using a prepare form. And what can we do? I mean, this is ridiculous, isn't it? I mean,
no,
we're looking for social determinants of health, and now we're turning around and charging patients to do it.
Right.
There's such a disincentive for so many of the things that need to be done, in order for us to identify those patients that you're talking about. And it doesn't seem like we have a true partner in CMS. Is there anything as a group that we can do to change that? So, for example, Prepare, yes, they allowed us to do it without copay or deductible on annual wellness visits, but what can we do to get them to drop the copay and deductible on any visit that we think it's necessary?
Well, I think it's a great question, honestly. And when I started out in medicine years ago, I was in private practice, and I had an idea that my husband and I were going to be in our private practice, and we were going to raise our kids there, and we were going to bring our dogs into the practice, and we did all of that, and it was wonderful. Medicine changed. That's not a sustainable practice. We all know that. But I will tell you that the Dr. Mindy from that many years ago would have never thought that she would be going to Washington and being on the regional policy board for the American Hospital Association and knocking on senators' doors. But the Mindy of now is saying that's what we have to do. When I sit on the regional policy board, I'm one of only 2 or 3 physicians in that group. So we need more activism as physicians. I mean, we're not going to get these things fixed if it's not physicians stepping up and saying we have a real problem. So what can we do as a group? We can advocate, we can knock on those doors, we can just do more, be part of the West Virginia Hospital Association, be part of the West Virginia State Medical Association. Those are the things that we really need to do. And I swear I have like an itch thinking about politics, period. But we have to do it. I mean, nobody else is going to stand up for our patients like we can. Now, on a more local level, I will say that one of the things we did, we made sure compliance figured out that it was okay, but we have an application form. So if we have a patient who is on a fixed income and we feel like they need pain or chronic care management, they can apply through our charity program, and the foundation actually is paying for their copays if they meet the criteria, which is pretty, most of our patients meet the criteria. And so that's something that we've just done locally so that we can do chronic care management without them having to worry about the cost of it. So that all goes through the finance committee. They meet the criteria, and then the foundation is stepping in and paying those copays. So on a more local level, those are some things that you can talk to your own foundations or whatever charitable groups and say, hey, and if it's helpful, I could probably share how much the foundation is paying a year for that. We have a pretty robust chronic care management program, I think. I don't know the actual number. Probably one of my colleagues on here might know it. But we do have a pretty, Tiffany, are you on? Do you know how many we have?
Yes, I'm one here. I think our last month numbers, we were actually at almost 70 with chronic care management, but we also do a lot of patient-centered health improvement plans, or PCHIPs. So though we can't bill for CCM through that, it's part of our patient-centered medical home accreditation that we provide those patients essentially with the same type of service, and then we do that through a PCHIP.
So, but for the 70 to 80 that we generally carry, if anyone's interested, I'm sure I can find out what the cost is to the foundation for that. Other questions? Nancy?
I have another. Thank you. That was a really good, a good response, and that's a great way around the problem. So I would be really interested to hear about your foundation. The other question I had is, I wondered if you or anyone on the call has used the new clinical health integration services, the CHI services that are now available through CMS for payer year 2024, where you can have anyone in your office, anyone, even an MA or even a social worker, contact patients for integrated services, especially if they have a positive on a prepare form or a social determinants of health survey. And we haven't done this. I'm just wondering if anyone else has. There's also a patient navigator opportunity, a principal navigator. I can't remember the codes, but it's also another way to get more people involved with your patient and still get payment from CMS. But it requires that you actually train these people and have a formal program. And just wondered if anyone else has actually started using that and if it's been successful.
We have not. If you could put a link in the chat to some kind of information on that, that would be great. Has anyone else started using that? sounds like probably no, but yeah, if you do have a link that you can put in the chat, that would be wonderful, that people can start looking into that. We have started using that thank you, the G2211 code for more complicated patients, and I'm seeing that a lot of my providers are picking up on that too, which, I mean, it's an extra $12 to $16 that you get paid for the organization. But I mean, for those of us in primary care, I mean, I would say 98% of my patients have more than one chronic condition that I'm addressing in each visit. So if I'm seeing, 100 patients a week and I'm adding that 99 for the whatever G1122 or 2211 or something, that's bringing more income in, and that's not costing your patients anymore, which is nice. Thank you for that.
Dr. Lohace, I was just going to say, we used to send our health coaches through, it was the Iowa Consortium of Care training for certified health coach training, along with motivational interviewing. And we had a lot of success with that program when we used it. Well, when we went back to our current ACO, and now we're switching at the end of this year, they had their own health coach training that we started doing. But that other program, if we used it for our employees to have that designated education, it may be valuable for that one you were talking about.
If you have a link for that, Tiffany, that would be great too.
Yeah, I can find that and send it.
Thanks, Tiffany. Are there any other questions? I'm sorry I ran through that so fast, but if anybody wants copies of the slides, be happy to send them out. But if there's no other questions, then you guys get 15 minutes back because I talked fast.
Thank you, Dr. Chua.
Thank you so much.
Thank you, Dr. Chua.
And just a reminder to everyone on the call, we will post this video to our website, and